This is a fantastic gathering. We love seeing everyone come back every 3 years to Baltimore. Hopefully we'll see in another 3 years in Baltimore. And it's really remarkable as interested as we are and as committed as we are to taking care of your children, taking care of you, and that's an ongoing commitment, which I'll say a few words about in just a moment. Really, you guys are the ones who are doing the amazing work. You're living with this day to day. We see you intermittently every, once a year, once every few months, but really this is for the families, by the families, and you're going to be seeing actually some of the fruits of your labor in one of the talks later on, specifically the Hemispherectomy Foundation. So it's going to be kind of fun to see what you as families can do, the kind of power that you have. So I wanted to thank Chris and Christy and Monica, I don't know where Monica is, for all of their hard work organizing this conference. Johns Hopkins and Kennedy Krieger are committed to continuing to care for your children, to care for you, and for you too. And you're going to see we have some changes. We've been expanding our program a little bit, and you're going to be hearing from some folks this morning who are new members of our team. And rather than hearing from the same old people over and over again, really what you're going to be hearing is some new work that's being done, some fresh faces. So we're really looking forward to this morning. The first fresh face who I'm really thrilled to introduce you to is Dr. Jay Salpekar. Jay did his post-medical school training, his residencies and fellowships at WashU and at Yale University, and then he was director of outpatient psychiatry at DC Children's, and then Kennedy Krieger had the foresight to recruit him up to Baltimore, and he's now the director, as you can see, of the neuropsychiatry and epilepsy program at Kennedy Krieger. He's an associate professor of psychiatry. I just promoted you at Johns Hopkins, but Chris will provide the paycheck. I can't. Yeah. So it's a real pleasure to hear from Jay. He's going to be talking to us about autism and behavioral concerns. The one other thing that I'll say is that the agenda this morning was driven largely by requests from you, from the families, that Chris then forwarded to me, and we were talking to some families too. So really, this is your agenda. So without further ado, Jay.
It's great to be here. It's wonderful to see everyone. And right away, I just want to echo what Dr. Hartman said. We are, as physicians, as therapists, as clinicians, we are inspired by what you do and by how you live, and that you thrive. And it's a great pleasure to talk to all of you and to present. I want to talk a little bit about what I do and about autism and behavioral concerns. There are certainly overlaps for a lot of different types of medical conditions and neurologic conditions. My role, I'm a neuropsychiatrist, and I specialize in pediatrics, and I do a lot of work with the epilepsy complications and with people with epilepsy that have kind of ripple effects in terms of behavior, cognition, other types of concerns, and we try to sort out what has to do with the brain and what has to do with something else. The slides will be just kind of a loose guideline. I have a fair number of them, a little bit of an ambitious slide set, but I promise we'll save some time for questions at the end. Developmental disabilities. This is a huge category. There are a lot of things that fall under this umbrella. We certainly think that they start early, and we know that they can be classified as severe, profound, mild. There's a variety of ways to classify them. We do think that it's somewhere in the 1% to 2% range worldwide. We know that it is present internationally through all sorts of different cultures and societies. There is something about developmental disabilities and even autism spectrum that seems to persist. The term intellectual disability is preferred, ID, and then sometimes we even add intellectual and developmental disability, IDD, and we'll see that a couple of times. Autism spectrum, the nomenclature has changed over the past few years too. We used to call things Asperger's or high functioning and even pervasive developmental disorder, PDD-NOS. That was one of my favorite diagnoses in the DSM because I like the not otherwise specified aspect of it, and that certainly captures a lot of what we all face every day, we're in the other category. We're in the complicated category. They're not clear descriptions or certainly not clear labels for what we do. Well, now the only category that's left is autism spectrum disorder. And that does indicate, and it certainly reflects that there is a spectrum. There's a variety of things that we will face that fall into that category. There are key features for autism. We know there's probably a triumvirate of sorts. And the first has to do with social relatedness. There's something about social interaction. There's something about connecting with others. There's something about interactional style that is atypical for autism or for autism spectrum. Sometimes we see kids or even adults that they're not motivated by social interaction. They do not seek interest or take initiative to engage socially with others. Then we also see impaired communication or language, and that's a big one. Sometimes it's a matter of speech patterns, sometimes it's a matter of the cadence of speech, sometimes it's a matter of the tone of voice, sometimes it's a matter of the actual language or the actual words. There are some people that will speak in a very deliberate manner, very stippled, very monotone fashion. There are other people that will have language deficits in terms of being able to process and sometimes even have speech structure or semantics that are a little bit different. And that can fall into the autism spectrum too. And then, of course, what we see a lot, stereotypes, repetitive, idiosyncratic behaviors. We have a lot of kids that are on the autism spectrum that have very narrow interests. And one of my friends now, he comes in and we talk about the train schedules all the time. And we like to look out the window and see if the train will come by. And he's a great kid. He has his challenges, but we talk about train schedules. And he one day, one of our greatest sessions, he brought in a little train radio, kind of like a police radio where you monitor the train comings and goings. And so we listened to that for a while. I had fun. And of course, it was the best thing ever for him. So a lot of idiosyncratic activities. They can get a very narrow focus, very limited range of interests, and that can sometimes be part of autism. May or may not have intellectual disability, and sometimes if they do, there's a wide split between verbal abilities and nonverbal abilities. Now, all these are important because it certainly implicates the behavior troubles that we might find later on, and I'll talk a little bit about that too. I will mention, because this question always comes up when I talk about autism, people want to know, well, is it increasing in prevalence? I don't have a great answer for that. There's no question that if you look at epidemiologic studies or at least think about percentages that are reported for autism, it seems like there is more now than there was, say, 30, 40 years ago. That might be an artifact of our identification process. It also might be an artifact of the way that we have broadened the criteria a little bit. In my mind, I think it might be increasing, but I think it was there all along. I think that we didn't recognize it, and there were a lot of families that really didn't come public at all if they had a child or a teenager that had untoward behavior in many situations, and they would just be isolated. Thankfully, that's not the case so much anymore. We can at least offer some services and some advice about how to manage some of these behaviors. So I think that people are a little bit more bold about seeking help and coming to attention, clinical attention. A lot of people will think that, and by the way, 35%, this is a pretty good database that was done some years ago. About a third of autism will have clinically significant aggression. And there is, for some reason it is common with autism and more common than psychiatric illness, than the general population. And that might be, it's not necessarily a deliberate aggression, but it is problematic and it's clinically significant in a lot of ways, and something that we try to sort out. There are a lot of people that think that irritability, aggression, increased physical activity, that these are constituent parts of autism or intellectual and developmental disability. I don't think that's the case, but it certainly is common, and there could be reasons for this, and I'll share with you the thought process of how we try to understand what to do. I'll talk about these studies for medicines. These are probably the two best studied at this point. risperidone and aripiprazole. We've all seen commercials for that, not risperidone anymore, but they're fairly prominently used. And we do have some data about their effects too. Anyway, epilepsy is common in autism spectrum. Maybe as many as half the kids will have some sort of seizures, atypical or some sort of epileptiform findings on an EEG. A good 30% might have actual seizures, well-formed and categorizable seizures. Behavior problems, as I was mentioning, it's not 100%. Just because you have autism spectrum or intellectual or developmental disability does not mean that there is psychiatric comorbidity. We still have troubles defining it. This is one of those, remember how I like the not otherwise specified category, and the reason is because that captures our kids, that captures our population and what we try to sort out. If we were thinking typically, we'd be looking for one of these things: mood disorder, bipolar disorder, major depression, ADHD. We'd be trying to find one of those. We have our list of criteria. We can check off a box. If you have 5, congratulations. You have, something like that. Doesn't work. I don't have a copy of DSM. I haven't bought the new one. I don't need it. Doesn't matter to me because it doesn't capture what we do. We're way more complicated than that. Sometimes people try to break it down, and you say, well, we can have an internalizing disorder of some sort, meaning that maybe you're anxious, you're depressed, it's something internal to you that is causing troubles. Or you can have an externalizing disorder, or aggressive, or hyperactive. There's something that you can see, something outside of yourself. That's even hard too. And one reason that it's hard is because just like autism spectrum, or autistic disorder might be on a spectrum, some of our key problems, impulsivity, the acting before thinking, not having much delay between intention and action, and aggression, well, this crosses boundaries for just about everything that we see. This is the common thread right here for all these things, bipolar, ADHD, call it what you will, autism spectrum, fine, impulse. This is really the common thread. So maybe what we really need to do is understand that instead of those things. And that's how when someone comes to me in my office, this is what we try to do. There are other kinds of behavioral dimensions that matter too, and these things also might overlap different diagnostic categories or different categorical criteria: aggression, impulsivity, sleep, all these other things. Well, that might also work in the same way. So we try to think about this as a core symptom, and if we're designing a treatment plan in some way, then we try to identify what is at the heart of the matter. Now, the thought process. In a lot of ways, if we start with one of these core symptoms, aggression, let's make a decision. Is it spontaneous or is it reactive? Now, there's all kinds of people that have different ideas about it. Sometimes we talk about hot aggression or cold aggression, or it's premeditated or whatever. That's fine. Those are all. It's a way to try to understand what's going on. I try to keep it simple. I want to know, is it spontaneous or is it reactive? Do we have a child that can be sitting very calmly, very happy, and then all of a sudden jump up and start flailing around or hitting or kicking or doing something like that? That's spontaneous. Or is it a child that's sitting calmly, playing, and then someone goes up to them and says, hey, it's time to go. It's time for lunch. It's time for something. And then they start hitting or kicking or flailing around. Well, that's reactive. These imply different things in terms of our treatment, in terms of what we want to do with it. If you're spontaneous and it's severe, well, you're probably in medication territory. Remember, a whole lot of kids with autism spectrum disorder will also have epilepsy. Maybe discrete seizures, maybe possible seizures. They will have something disrupted in the brain that might benefit from an anticonvulsant or anti-epileptic medicine. So that's what we turn to in a lot of ways. For these spontaneous, aggressive outbursts, we think, well, geez, probably medication territory. If they're reactive, then we say, well, maybe we can assess that a little bit more. Is this like 0 to 60 in 2 seconds? You're probably in medication territory there too. Does it slowly develop? Well, let's try behavior modification. Let's see if we can't redirect. See if we can't do the strategies that you all do of saying, here's your 2-minute warning, here's your 10-minute warning, let's do this or that. Give some choices. Let's gradually build up to whatever behavior we're trying to shape or redirect. And then we can maybe avoid using a medicine. So this is our template, our standard. And then when we get to medicine, there's a lot of things we can do. We can get to behavior modification. There's a lot of things that we can do too. Talk a little bit about that. So the first thing, sure, rule out underlying conditions, environmentals. Try to figure out what this actually means. Many times there are physiologic or homeostatic physical needs of some way that are interfering with this. We have a lot of kids, and remember, these kids they're not necessarily responding to social cues, to other external environmental cues. Sometimes it's a matter of their perception. Sometimes it's a matter of, geez, if I took away my, my friend's train radio, well, he'd be aggressive. Or if I said, we have to turn that off right now. I mean, this is the most important thing in the world to him. We have a lot of problems with perseveration and kids who are have these stereotyped interests. If you take that away, or even if there's a fear that that might get taken away, we can get an aggressive response. So we have to figure out what this means. It is very helpful to us, to me certainly, if we can measure any amount of detail. What time of day? Was this after lunch? Was it before lunch? Was there a new person involved? Was the ambient temperature somehow awry? Was there something different in terms of the mood, the noise, anything else? Those are all important clues because we want to know what sets off the aggression and if we're in medication territory or not. Very big. Changes in staff, caregivers, that's huge. Sometimes there's even a lag time. If you change a caregiver, sometimes, kids, they might not recognize it right away. It might be 2 weeks later where you have these behavior disruptions. So you say, wow. And say, well, how could that be the change in caregiver? That was 2 weeks ago. It takes a while sometimes for the processing and for, in order to incorporate that change. So we will see that sometimes weeks later. These are all non-pharmacological treatments. Structure, of course, predictability, yes, social skills, even rudimentary social skills, greetings, these are all important tools. We don't want to lower the bar in terms of social relatedness, social interaction, if we can help it, if we can possibly help it. Communication, certainly. We work a lot on communication, and then sometimes if you can have individual therapy, at least to put words to feeling states. Oh, you feel angry. Kids don't often know how they feel. We have to tell them. We have to say, oh, that's because you were afraid. You were sad. Sometimes they need to have that instruction. Anyway, here's an example picture board. If someone is nonverbal, then you want to have things to remind them. Different things, different clues. And then coordinate routines. I'll go ahead and get to medicines here. Here's the thing. Expect paradoxical reactions. None of our kids have read the textbooks, so they're not going to act accordingly. There'll be a paradoxical reaction. We have to expect it. And that happens all the time. People come in and say, oh my gosh, I've never seen that. We'll do a literature search, sometimes in the office. No one's ever seen that. Well, that's the territory we're in, so we have to expect it. And the other thing to expect is that we don't know what's going to work sometimes. The most important thing is decide, are you in medication territory or not? If you are, well then we can try to think very deliberately, very proactively. Let's see what might make sense. We have to identify target behaviors. We might not have categorical diagnoses. We might not even have behavior dimensions in some cases, but we do need to know what we're trying to treat. In our kids, sometimes we don't have these same criteria. Instead of, depressed mood, we might have a lack of reactivity. We might have, change in the total sleep time instead of a clear initial insomnia or someone that wakes up 3 hours too early every day. We might have some variability. Instead of, being hyperactive, they might be, self-injurious. All right? Negative statement. This happens all the time. A lot of our kids, we don't think they know where they stand, but a lot of them do, and they realize it, and we have to help them when they do. And then, when it gets really bad, when we think about depression or even suicidality, well, sometimes it's not that we see, but we have these other preoccupations, and especially for kids in the autism spectrum, if you're perseverative about something, sometimes it's very hard to shake that idea. Anyway, there are more of these kinds of things. A word about, just to reinforce a little bit about what self-injurious behavior may mean. Kids who will do things to hurt themselves. They'll bang their heads. They'll, throw themselves against a wall. Anything like that. Often it means something. Now, sometimes there's an underlying psychopathology. Sometimes it means pain. Sometimes it means discomfort. Sometimes it means they're disoriented. Sometimes it means they're frustrated. They don't know what to do. They don't know how to react. Sometimes it means they're tired. Sometimes it means they're afraid. There's usually something behind self-injurious behavior. Usually. Not always. Whoops. There we go. Anyway, I want to get to the medicines here. Talk just a little bit about this, and then I'll open it up for questions. I pretty much covered everything, as you can tell. A lot of different medicines. Sometimes they work. Mood stabilizers, well, sure. We can use an anticonvulsant. Anticonvulsants are great, And the whole range of anticonvulsants, carbamazepine, oxcarbazepine, valproate, you name it. There's a whole lot of them. Why? Because they calm hyperactive neurons that turn on too quickly. If you have spontaneous aggression, that is what's happening. So we want to turn off these neurons. We want to calm them down. So sometimes anticonvulsants are our best bet. We'll start with that in a lot of ways. SSRIs, those are antidepressants, serotonin selective reuptake inhibitors. Not a whole lot of great data with autism spectrum, but it's still meaningful. And sometimes you can cure people. Sometimes kids, especially who are depressed, or if you're on the autism spectrum plus depressed, sometimes there's impulsivity, there's aggression that can come from this extreme irritability. Well, that's the target of an antidepressant sometimes, so we do consider that. Atypical antipsychotics, we'll talk tiny bit more about that. Drugs that reduce neuroadrenergic effects, beta blockers, alpha-2 agonists, clonidine, guanfacine. The branded product for guanfacine now is called Intuniv, which is it's a great product. I'm not on any kind of board for Intuniv for anybody really, but this is trying to capture this level of neuroadrenergic effect and trying to produce a global calm. Sometimes it works. These are mild medicines. They're not as big league as an anticonvulsant or antipsychotic, but sometimes it works. And then stimulants. A lot of kids, will take methylphenidate or dextroamphetamine, and sometimes that can help. After all, part and parcel of ADHD is impulsivity, acting before thinking, and sometimes the stimulants will help with that. So, a lot of choices. The key thing is decide if you're in medication territory, then decide what your targets are, and then you can kind of piece together very gradual treatment trials, and then see if it's tolerated, see if you have the effect that you want. Anyway, I will get to these two. Risperidone, aripiprazole. That's the best data that we have. Doesn't mean that it's great data, but it is the best that we have. These are this research unit on pediatric psychopharmacology, the RUP studies as they were called, they were clever. They were very sophisticated. But they essentially said, okay, these medicines seem to be effective for aggression in the context of autism spectrum disorder. Problem with with risperidone certainly is that 69% side effects. Weight gain was a big one. So these are, you don't get to have the benefits for free. That's why it's extra important. You make sure you're in medication territory first. Aripiprazole, same type of thing. All right, anyway, I think I've summarized enough. I want to show you these references. These are pretty good. CDC.gov, it's a great report on the current state, the prevalence of autism spectrum disorders. And these are pretty good articles too if you want to know more about risperidone. And a pretty good review. I mean, I was impressed by these guys. They went through all the studies, a meta-analysis, and none of it was that dramatic. But if you want to learn a little bit more and know, what you're facing, go ahead and read it. It'll be worth your time.